Hi kids, so now let us discuss about the hormones of your pituitary gland, particularly about your posterior pituitary gland. So just a recap regarding your posterior pituitary gland, recall that it is an extension of your hypothalamus. So basically, what is being secreted in your hypothalamus is transported directly to your posterior pituitary gland, and posterior pituitary gland is considered to be their storage area. Now, as long as there is no any stimulus or any signal being sent to your hypothalamus that the hormones are needed, then therefore it will just stay in the posterior pituitary gland, particularly in your nerve terminals. Now, there are only two hormones in your posterior pituitary gland, and these are your oxytocin and your antidiuretic hormone, which is also known as your arginine vasopressin or vasopressin alone. So this table would already summarize how these two hormones are secreted and what are their functions. But of course, we need to discuss them thoroughly, and thus our discussion for today revolves around these two hormones as to where they are produced, what controls their secretion, what are their roles, what are their clinical significance, and how do we diagnose them. So, of course, we will include in our discussion the different laboratory methods used in order to measure their levels or concentration. So, for these two hormones, they are actually small oligopeptides, meaning already only contains around 9 amino acid residues. And looking at the image here on your right side, of course you will not need to memorize all the 9 amino acid residues. So what I would like to point out here is in which area they differ. So the first is on the third amino acid, wherein your oxytocin contains your isoleucine, while for your ADH, that is your phenylalanine. And the last would be in the eighth amino acid, wherein for oxytocin, that is your leucine, and for ADH, that is your arginine. Now, this one, we have mentioned this in our last topic regarding your hypothalamus and anterior, wherein both your oxytocin and ADH are synthesized in the magnocellular neurons of your paraventricular and supraoptic nuclei of the hypothalamus. So just to present the specific area where this paraventricular and supraoptic nucleus are found, so it is here in these certain areas. And again, there are a lot of types of neurons and nuclei here in your hypothalamus, of which they have specific roles. But of course, here in our discussion, so just focus on your paraventricular and supraoptic nuclei being the two nuclei responsible in the secretion of your oxytocin and ADH. Now, again, they are transported along your axons going to your posterior pituitary gland, and as long as there is no stimuli, then they will just be stored in your nerve terminals, specifically in your secretory vesicles. So being a peptide hormone, as we discussed in the introduction to hormones na topic in our lecture period, diba, all of your peptide hormones are murag ang last or storage nila is really inside the secretory vesicle, where their final cleavage of the active hormones are done. And as long as there are no signals or it is not needed, then it will just be stored there inside your secretory vesicles. So now let us discuss your AVP or your ADH. Now, the half-life of your ADH is around 18 to 20 minutes. The image that you see here on your left side is referring to your 9 amino acid residues. And then for the function of your ADH, so we all know, diba, because we've been mentioning a lot about your ADH, especially during our introduction to electrolytes, that ADH functions for water reabsorption. So stated here in your first function, It maintains osmotic homeostasis by regulating your water balance, and it will stimulate also contraction of the muscles of our capillaries and arterioles in order to raise our blood pressure. So recall that ADH is important and is also a part of your RAAS, your renin-angiotensin-aldosterone system, of which RAAS, the main purpose of RAAS is to increase your blood pressure and increase your blood volume. And thus, ADH is involved because, again, it is for water reabsorption. And as stated here, other than water reabsorption, it will also stimulate contraction in order to raise your blood pressure. So other functions of your ADH, number 3, is to promote contraction and intestinal musculature, increasing now peristalsis. So when we say peristalsis, for discussion's sake, peristalsis is a series of wave-like muscle contraction that will help move our food or anything that we consume to different processing stations in our digestive tract. And then lastly, it will also exert contractile influence on our uterus. I think this is also referring in terms of during labor. So, with hormones, we've also discussed in the introduction to hormones that in order for your different hormones to elicit its function, but it needs to be to bind first to their specific receptors. And receptors are actually somewhat parang parang telling them that this is their particular target cell or target organ. So for ADH, there are 3 different receptors. You have your V1, your V2, and your V3. So V1 is located in your blood vessels. So therefore, yung function ni ADH in relation to contraction, so V1 receptors po siya. So located in your blood vessels and it is responsible for your vasopressor action. V2 receptors are in the basolateral membrane of your collective tubules in the kidneys. So meaning to say, V2 receptors, once your ADH will bind to your V2 receptors, so water reabsorption will happen. And the last would be in relation to your V3 receptors, which will cause stimulation of your ACTH secretion in your anterior pituitary gland. So as to why your ADH will cause stimulation to your ACTH and what is its role, so we'll just discuss that further as we go along our discussion. So let's proceed. So let us discuss first about your V2 receptor. So again, ADH will stimulate your V2 receptors, and that V2 receptors are found on your principal epithelial cells that will line in our cortical collecting ducts of the kidney. So basically, if you are being asked as to which specific portion of your kidneys will water reabsorption happen, which is being acted upon by your ADH. So that would be in your cortical collecting ducts. So what happens here? By the time your ADH will bind to your V2 receptors, it will induce an increase in the production of your CAMP, being your secondary messenger. So, diba, I made emphasis about this na kung peptide hormones sila, always CAMP signaling mechanism yung mangyayari. Whether we are talking about specific hormones na like this one, your ADH. So again, the action will still be the same. It is in terms of the production of your CAMP. So yung discussion natin about yung CAMP signaling mechanism, it follows. So merong activation of your G protein, merong formation of your CAMP by the action of your enzyme, your adenylate cyclase. And then what will happen upon the production of your CAMP? It will cause now your water channels, specifically called your aquaporins, to fuse with the apical membrane of your principal cells, and thus increasing water permeability and reabsorption. So basically, kids, aquaporins would play a very vital role in terms of controlling the water content of our cells, in terms of controlling our cortical collecting ducts if it's really time to reabsorb water, or if there is really a need to reabsorb water. So to explain in detail as to what is happening as to what is happening in the activation of your V2 receptors and the action of your ADH. So consider this image. Actually, this is not an image. This is a GIF. So as you can see, this is the cortical collecting duct. This is your basolateral membrane in this area. So kaya siya basolateral, kids, because it is facing where your blood vessels are. So this red portion here refers to your blood vessel. And then your apical membrane, this portion is facing your lumen. So kaya ito siya yellow because this is referring to where your urine will pass through. Now, initially, your cortical collecting ducts normally is impermeable to water. So that is the role now of your aquaporins. Once your aquaporins, this is actually the image of your aquaporin. So once your aquaporin will bind to your apical membrane, it will signal this whole epithelial cell na it will become now permeable and it will now reabsorb water. So as long as wala po tayong aquaporin na nakabind sa apical membrane, no water reabsorption will happen and your cortical collecting duct will still be impermeable to water. So wala po talagang papasok. So what happens here, kids? As mentioned, your V2 receptors are found here. Ayan po yung mga blue dyan. Your V2 receptors are found in your basolateral membrane and of course, it is situated along along the surface. Kasi nga, di ba, your peptide hormones cannot enter directly into your cell and thus its receptors are situated outside or in the surface. So upon the binding of your ADH to your V2 receptors, so the same thing will happen although it is not presented here, but ganun pa rin po yung sa ating CAMP signaling mechanism. It will activate your G protein and then G protein will look for your adenylate cyclase and then ATP will be converted to CAMP through the activation of your adenylate cyclase, and then in turn, CAMP will activate your protein kinase, specifically your protein kinase A and here. And recall that the function of your protein kinase A in order to push through with the function of that hormone or your ADH hormone is through phosphorylation. So here, your aquaporins are situated or actually may mga preform po tayo na aquaporin pero andun pa siya, naka-embed or naka-enclose pa po siya sa ating vesicle. So in order for it to be released, protein kinase A is needed, making certain proteins, phosphorylating proteins that will cause the release of your aquaporins in the vesicle. And then by the time ma-release the aquaporin, it will now bind in your apical membrane, making now your cortical collecting ducts permeable to water. So thus, water will enter and then dire-diretso po yan siya until na ma-release sa blood vessel. And then water reabsorption now will happen. So ganun po yung whole process ng ating V2 receptors, kids. Again, same ang mangyayari in terms of our discussion about CAMP signaling mechanism. Yung nadagdag lang po is in terms of the presence of your aquaporin. Na through phosphorylation, it will be released inside its vesicle and will bind to the apical membrane, and then water now can enter into your cortical collecting ducts until such time that it will go back to our circulation. So let me just point out that there are actually a lot of types of aquaporins and it is situated in the different areas of our epithelial cell. What you need to remember is your aquaporin 2 because as stated here, it is specifically for the reabsorption of water which is in response to your antidiuretic hormone. So now let us discuss about your V1 receptor. So again, your ADH act as a potent pressor by causing vasoconstriction by the time it will bind to your V1 receptors found on your blood vessel areas. And other than that, it will cause the stimulation of your clotting factor 8 and your von Willebrand factor, which is being released by your endothelium. So yung mga factor 8 and von Willebrand factor, kids, you will get to know more about this in your hematology. Sa part po yan sila ng ating coagulation cascade. And your V1 receptor or this activation of V1 receptor is being modulated by any changes in our osmolality and if there are alterations in your intravascular volume. So now let's focus on serum osmolality and intravascular volume. So again, when we say osmolality, this refers to the concentration of your solute. When we talk about intravascular volume, so basically this talks about the water content in our body. Now with serum osmolality, kids, it stimulates the release. What stimulates the release of your ADH would be your osmoreceptors. So osmoreceptors are found anywhere in our body na kung if there is an increase or decrease in the concentration of our solute, si osmoreceptors yung ma-activate and siya din po yung magbibigay ng signal to our hypothalamus to release ADH. And then, of course, recall your thirst receptor, kids, which are found in your hypothalamus. Na basically, its function is to tell our body na we are thirsty. So, in short, we need to drink water. Now, the reference range of our osmolality is around 275 to 295 milliosmoles per kilogram. And if our osmolality would go beyond 295, then our ADH will be maximally stimulated. If it is lower than 284, then it will be suppressed. Because then again, if increase ang osmolality, then that would mean that there is a decrease in our water concentration. If decrease ang osmolality, then it would mean na taas or there is more water in our body. So kaya dapat isuppress siya. So this table will show you that as long as our osmolality concentration increases, thus your antidiuretic hormone concentration also increases. And by the time it will reach around this concentration, kung nasa 295 and above na siya, then your thirst mechanism will also be activated. So again, what controls your osmolality are your osmoreceptors. Now, how about your intravascular volume? So, kung osmoreceptors for osmolality, baroreceptors for your intravascular volume. And there are two types of receptors here. We have your low pressure volume receptor and your high pressure arterial receptor. So, syempre, when we talk about syempre, depende kung taas or baba yung ating blood pressure. So, ito po sila yung maa-activate. So, literal, pag low pressure, then, which are found in your right atrium and pulmonary venous system. So, sila yung magbibigay ng signal to our hypothalamus na baba yung pressure or kung high pressure, then taas yung blood pressure ng body. So, for high pressure arterial receptors, they are located in your carotid sinus and your aortic arc. Now, take note that the secretion is much more sensitive to changes in your osmolality rather than changes in your intravascular volume. Tingnan nyo, kids, just around 1 to 2% na change sa osmolality or 1 to 2% increase sa osmolality, it will immediately cause a rise in our ADH secretion. But if we're looking at changes or drop in your blood volume or blood pressure, it will take around 5 to 10% drop pa bago mag-trigger ng release ng ADH nyo. And the reason behind this, it's because hindi naman kasi talaga sa ADH yung ating primary hormone para mag-correct in terms of blood pressure. Diba? Again, main role of your ADH is in terms of water reabsorption. So thus, mas maa-activate siya if there are changes in our osmolality. So, yun lang po talaga yung parang rationale behind it. Okay? So, now let us discuss about V3 receptors. So, again, V3 receptors will cause a stimulation of your ACTH. So, let me just remind everyone about ACTH kasi last time during our quiz na yung may answer na ACTH And given that you are not allowed to write down the abbreviation, again, yung A dyan, that is I hope makita siya, kids. So, ayun. Hindi po siya adeno, it should be adreno because ACTH is because ACTH yung kanyang, although it is secreted in your posterior pituitary gland, posterior, anterior pituitary gland, yung target organ niya kasi is adrenal gland. So just think of your adrenal gland, then therefore, yung name niya, yung letter A dyan, dapat adreno. Adrenocorticotropic hormone. Again, please, sana po, di na po magkakaroon ng ganitong mistake na. Again, that is adrenocorticotropic hormone. So V3 receptors will cause the stimulation of your ACTH, which is being secreted in your anterior pituitary gland. Now, what is mainly the purpose of your ADH as to why it will stimulate the release of your ACTH? Recall that the purpose of your ADH, di ba, is to retain your water. Kasi nga, water reabsorption. Now, it can reabsorb water in two different ways. It could be through acting on your kidneys. Yan yung primary. And the second is through stimulating your ACTH. Now, ACTH causes your adrenal cortex, kids. Kasi nga, siya yung andun sa anterior nyo. Target organ si adrenal cortex. It will give a signal to your adrenal cortex to release now your aldosterone. Aldosterone will act on your kidneys in order to reabsorb your sodium. And every time sodium is being reabsorbed, water is also being reabsorbed. So yun yung reason behind why ADH will cause stimulation of your ACTH, because the stimulation of your ACTH will help also in retaining water in our body. Simply put, that your ADH is trying to ask for help, diba? It's asking for help sa ACTH nyo and sa aldosterone specifically to keep water in our body. Kasi nga, whenever sodium is being reabsorbed, water will also follow. So, yun lang talaga yung main point dito and yung role ni ACTH. So, I hope na gets po siya. So, these are just other stimuli of ADH, mga non-osmotic stimuli of ADH. So, it could be pag may nausea, or if my presence or increased concentration of your cytokines, interleukin 6, or if my use of nicotine, or if my hypoglycemia and hypercarbia. So when we say hypercarbia, kids, this is in relation to elevated levels of your carbon dioxide in the body. So next, ADH normal range is around 0.5 to 2 picograms per UL, and it is in concert with your ANP, your thirst, and your RAAS. And there are 3 things that your ADH will try to maintain: your blood pressure, your volume, and your tonicity. So we've already discussed about your blood pressure and volume. So how about tonicity now? Diba? Tonicity is referring to the ability of the surrounding fluids to cause your cell to either gain or lose water. Diba? Remember your hypotonic and your hypertonic. Now, what happens here, kids? Pag pag hypotonic yung fluid natin, it will mean na lesser ang solutes. So therefore, mas marami yung water. So kaya as you can see here, since there are more water outside than inside, then water will be taken up by our cell, causing it to swell, and eventually, pag masobraan ng absorb ng water, diba, it will burst and it will hemolyze. On the other hand, pag hypertonic, meaning increase yung solute, meaning there is less water, and since there is less water outside, then therefore, water in your cell will go out until such time na, di ba, mag-crenate na siya or mag-shrink. Now, as to ADH, pag hypotonic siya, kids, syempre kasi mas marami na ang water, then mababa yung ADH or walang stimulation, suppressed. But since here in hypertonic, mababa yung water, then therefore, there should be stimulation or increased concentration of your ADH. So that is how tonicity could affect our ADH concentration, because tonicity affects the level of water, then therefore ADH will also try to maintain the level of water by either stimulating or suppressing it, depende kung hypotonic or hypertonic. As for this one, so I guess there is no need for me to really discuss this because we've been mentioning this a lot, diba, regarding your RAAS. And here on the right side, this is just referring to the presence of your ANP. So just remember that RAAS will be activated if decrease yung blood pressure or decrease yung blood volume. ANP will be activated if increase yung blood pressure or increase yung blood volume. And it is a cascade of a lot of hormones being involved just to correct the decrease of your blood pressure and blood volume. So kaya RAAS siya, diba, involves your renin, angiotensin, aldosterone, and other hormones pa, which includes your ADH, and even stimulation of your thirst mechanism. So ADH, kids, if in case there is no direct, hindi available yung testing for your ADH, there is no direct measurement to it, then we could also just measure our plasma osmolality. Again, the normal range is around 275 to 295. Measure also your sodium, kasi again, our sodium is our major regulator also of our osmolality, kasi nga siya yung may pinakamataas na concentration being a solute, and it is around 135 to 145. So, to measure osmolality, we could use your freezing point depression osmometry or your plasma vapor pressure. But we could also indirectly measure osmolality by getting the concentration of these three things: your sodium, your BUN, and your glucose. And recall this formula na to measure your osmolality, multiply sa 2 yung sodium, si glucose i-divide sa 18, si BUN i-divide sa 2.8, and then add all those values, then that is already your plasma osmolality. Okay? Sige, so now we go to the clinical significance, and there are actually just two conditions related to your ADH. If there is deficiency of your ADH, then that is your diabetes insipidus. If may excess, then that is what we call your SIADH, your syndrome of inappropriate ADH antidiuretic hormone. So SI here stands for your syndrome of inappropriate. And then ADH, antidiuretic hormone. So start sa takay, hormonal deficiency in relation to diabetes insipidus. There are actually 4 types of diabetes insipidus. It could be your central or neurogenic, your nephrogenic, your dipsogenic, and your gestational. Now, yung major types are the first 2 here above. As for your dipsogenic, this is referring to your abnormal thirst mechanism. While for gestational, this is referring to diabetes insipidus that is happening during pregnancy. So again, dipsogenic is for abnormal thirst mechanism, gestational during pregnancy. So let us now focus on our 2 major types. So we have here your neurogenic, or again, this is also known as your central, and your nephrogenic DI. Now, you already have a clue Kids, sa pangalan pa lang ng types of diabetes insipidus, meron na po tayong clue. Neuro and your nephro. So when we say neuro, this is referring to your hypothalamus, neuro or neurons. So meaning to say, neurogenic DI is a deficiency of your ADH because there is a problem in your hypothalamus. Failure of your hypothalamus to produce your hormone. And neurogenic DI happens when there is pituitary tumor, traumatic injury, it could be autoimmune or it could be idiopathic. For nephrogenic, again, nephrons, think of nephrons, so meaning to say we are looking at our target organ here, which is your kidney. So what happens here in your nephrogenic DI is that there is a failure of your kidney to respond to ADH. And it may happen when there is renal failure due to drugs. It could be congenital defect sa receptor. So again, kids, let me just emphasize that with nephrogenic DI, there is normal concentration of your ADH. The problem here is receptors. Na kumbaga, yung V2 receptors na andun sa kidneys nyo, they cannot recognize ADH. So therefore, diabetes insipidus will happen kasi nga walang recognition. It will not respond to the presence of your ADH. So wala pa rin pong water reabsorption na mangyayari. And just to emphasize regarding what will be the concentration or unsa may itsura sa inyong urine, kids, syempre when ADH is present, kasi nga nagre-reabsorb tayo ng water, so you would expect that your urine is concentrated, puro solute yung andun. While if ADH is absent, our urine is diluted, kasi nga there is no reabsorption, so all of our water is being excreted in our urine. And just to point out once again, regarding the difference of your DM and DI, diba, your diabetes insipidus and your diabetes mellitus. Na again, with DM, the problem is your insulin. With DI, the problem is your ADH. Kaya lang naman talaga tinatawag na diabetes si diabetes insipidus because it shares the same symptoms with your diabetes mellitus na yun pong polydipsia and polyuria. And other than looking at the concentration of insulin and ADH, DM and DI could also be differentiated in terms of checking the specific gravity of your urine. Siyempre, for diabetes insipidus, decrease yung specific gravity kasi nga mataas yung concentration ng water sa urine because walang water reabsorption, then therefore, baba yung ating solute. But for diabetes insipidus mellitus kids, you would expect na increase ang specific gravity because there is increased glucose concentration in the urine. Kasi 'di ba, there are times na si glucose magiging present na sa urine ng mga diabetic individuals because it is the way of our body to remove glucose or to lower down glucose concentration in the circulation. So therefore, increase yung specific gravity because of the presence of glucose in the urine. So if there is diabetes insipidus kids, one test that we can perform is what we call your water deprivation test. So from the word pa lang po na deprivation, meaning to say wala po tayong iinumin na tubig. It involves not drinking any liquid for several hours and let us see how our body would respond. This is a preferred diagnostic test and response to either endogenous or exogenous. So ito na portion kids, we'll just discuss that later. So let us focus first on the procedure. So ito po yung procedure. So this is actually from your Henry's na reference book. So bali, as you can see here, patients with mild polyuria may be instructed to withhold all fluid intake from 10 p.m. onward. Pero pag severe yung polyuria, your water deprivation should start early in the morning under close observation. So depende siya kung mild or severe. So during testing, patient is forbidden to take any fluid by mouth. And before And of course, we need to get a baseline. So, kunin yung volume ng urine and osmolality, even your plasma osmolality, and including your plasma sodium, and then record the weight and blood pressure or pulse, seated and standing. And then urine and plasma are collected hourly and tested with those parameters. And then when your urine osmolality has plateaued, or when our body weight has decreased by around 3 to 5%, or the patient will already develop a drop in our blood pressure, then obtain na naman po tayo ng mga samples na kailangan. And then administer 1 mcg of your desmopressin, IV or IM, so either through intravenously or intramuscular. And then, ayan, urine output and plasma osmolality are recorded at 30, 60, and 120 minutes after the injection. Highest urine osmolality value is used to evaluate the patient's response to ABP. So, bali, ito lang talaga yung bottom line nito, kids. When we are deprived of water, diba, the expected result of your ADH should be increased. But if you have diabetes insipidus, even if we are deprived of water, ADH will continue to be low. So after nitong water deprivation test, if our ADH level will continue to lower down, we will proceed to our next step, and that is to do this endogenous or exogenous AVP or ADH. But before that, what would be our expected result in relation to, kasi nga, di ba kanina sa procedure, we will need to test both your plasma osmolality and urine osmolality. Now, if patient is normal, di ba, since wala po tayong water intake, we would expect that our ADH level would increase. And an increase in your ADH level will cause for your urine osmolality to increase. Why? Kasi nga, puro na solute ito. Kasi yung water, di ba? Yung water gina-reabsorb pabalik sa circulation. So, your plasma osmolality is decreased. Kasi nga, nag-increase na yung water level dito and decrease na yung ating solute. So again, just remember that whenever we talk about osmolality, this is referring to your solute concentration. On the other hand, to those patients with diabetes insipidus, of course, your ADH level will continue to decrease, and therefore urine osmolality is decreased kasi walang reabsorption. So, yung water nyo increased, yung solute nyo dito increased. And since there is no water reabsorption, then therefore plasma osmolality is increased kasi baba yung water concentration dito. So, water deprivation test is only for us to know if the patient has diabetes insipidus. Pag gusto po natin malaman as to what specific type of DI, then we will proceed with exogenous ADH. Again, explain ko po ulit, water deprivation test is only to know if the patient has diabetes insipidus. If we want to know the specific type of DI, then we need to proceed with this test, which is your exogenous ADH administration. Exogenous ADH kasi we are giving the patient a synthetic ADH being taken either by mouth or by IV ba. And by doing exogenous ADH administration, we would be able to know whether patient has neurogenic or nephrogenic DI. So try to look at our result. So syempre sa normal kids, even if we give ADH, plasma osmolality could either be normal or decrease kasi nga normally may ADH naman din talaga sa body. So meaning to say, increase dito kasi may water reabsorption, and then since papunta sa circulation, so plasma osmolality baba. So how about neurogenic and nephro? What would you expect for the plasma osmolality and urine osmolality? So may sudden pause lang kids. For me, I want you to think about it before presenting the result. Diba, what would you think would happen? Recall the main problem of your neurogenic and nephrogenic. Neurogenic ang problem nasa hypothalamus, therefore wala po talagang ADH. Nephrogenic ang problem nasa kidneys na although there is normal ADH being released by the posterior pituitary gland, but unresponsive sa kidney kasi ang problem is receptors. So therefore, by giving exogenous ADH, this will be your expected results. With neurogenic DI, since binibigyan na po natin sila ng ADH, parang nagno-normalize yung effect. Kasi nga may exogenous ADH na, then therefore, able to proceed with the water reabsorption, and then yung ating plasma osmolality baba na kasi nga there is already an increase in the water concentration. But with nephrogenic DI kids, walang effect. Even magbigay po tayo ng ADH again, there is no effect. There is still no water reabsorption because the main problem with nephrogenic DI are your receptors. Guba si receptor, then therefore ADH is not recognized. Then your urine osmolality will continue to decrease. Sige gihapon tag-ihi og water. And then, yung plasma osmolality increase kasi nga, walang baba yung water concentration na. So, I hope na gets yun, kids. Again, let me just emphasize once again kasi maraming students na nagkakamali pa rin dito. Water deprivation to know if may DI, exogenous ADH to know what type of diabetes insipidus. So, yun lang po for your diabetes insipidus. As for hormonal excess, which is your SIADH, so ayan po, syndrome of inappropriate ADH, which is characterized by hypersecretion of ADH. So, meaning increase ang ADH, so may excess water reabsorption, diluting our plasma components. So, what would be our expected lab results? So, whenever you encounter the word dilutional effect, that will really cause for your sodium levels to be decreased or solute concentration in general to be decreased. And therefore, your plasma osmolality here, kasi nga, di ba, sobra-sobra ang water, so baba ang solute. And for urine osmolality, taas ang solute, baba ang water, kaya nagsigita og reabsorb. And in terms of the test, opposite lang yun sa water deprivation kids. So, it is not really that difficult to remember kung water deprivation sa DI, then water loading test for our SIADH. So, ayan. So, normally, dapat around 80 to 90% ang ma-excrete na water load within 4 hours. But if may SIADH po tayo, it will fail to meet this criteria in the absence of medication or other conditions that may impair diuresis is consistent with the diagnosis of SIADH. So, literal, nabibigay lang po talaga tayo ng water dito. Ayan, patient is given 20 ml of water per kilogram of body weight, maximum of 1,500 ml to drink over 30 minutes. With the patient maintained in the recumbent position, urine output is collected every hour for the next 5 hours. So for this table, this just summarizes the different results of our test, but tests in the differential diagnosis of disorders of your water homeostasis. So we'll leave this one for you to read. Okay? So that's it for your ADH. So now let us proceed with your oxytocin. Now, oxytocin, kids, yung kanyang ang main talaga na function ni oxytocin, dalawa. Promotion of uterine contraction and milk ejection. Again, just remember that two, uterine contraction, milk ejection. So, oxytocin will stimulated by stretching of the cervix and vagina during parturition, which we call Ferguson reflex. So, yan yung during labor. And then contributes to uterine contraction in labor both by the direct action in your myometrium When we say myometrium, kids, this is the smooth muscle tissue of our uterus, and it will also stimulate your prostaglandin secretion by your decidua. Prostaglandin is a different substance that will also help promote uterine contraction. So, para siyang helper din ng oxytocin. Para siyang ADH and ACTH na relationship wherein oxytocin will also ask for help sa prostaglandins nyo in order to promote further yung uterine contraction. As for decidua kids is our term for uterine lining during pregnancy, which will form the maternal part of our placenta. So, ito po siya. So, ganito po during labor kasi nga 'di ba kailangan naman talaga ng uterine contraction para ma-release yung baby. So your fetal ejection reflex is also known as your Ferguson reflex. Take note, it is involuntary. And an increase in the pressure of our cervix or vaginal wall will cause a release of your oxytocin, which will bring on contraction until the baby is delivered. So until such time na hindi pa lumalabas yung baby, then it is a cycle na increase na naman ng pressure dun sa cervix or vaginal wall nyo, release na naman po tayo ng oxytocin, contraction na naman. Until yun na nga yung point, this is for our baby to be released. And then, yung second function ng oxytocin nyo in relation to milk ejection, ayan, milk ejection. So, oxytocin will stimulate your myoepithelial cells, that is what is surrounding your mammary gland, and your lactoferrous ducts to contract, resulting in milk ejection. And these three things are your stimuli. So, when there is suckling of your nipple, anticipation of nursing, and upon hearing a baby's cry. But of course, kids, again, our body knows when we get pregnant, then therefore, that's the only time na may milk na production and ejection na ito na mga stimuli magkukos talaga ng milk ejection and production. If you're not pregnant, no matter how much you hear a baby's cry or if may nipple suckling, wala din talagang milk. Diba? Again, makulbaan ta anak girls or boys na ay mga ingani dayon na effect sa atong body na makadungog lang dayon tanong mong hilak ng bata. So again, this is in relation to pregnancy. So just to point out na ayan po yung myoepithelial cells. Now, take note that your milk is initially secreted dun sa ating alveoli, from which it must be ejected for consumption of the baby, and that your alveoli is surrounded by your myoepithelial cell, ayan, which are the prominent target cell for your oxytocin. Oxytocin then will stimulate contraction of your myoepithelial cell, which will now cause milk to be ejected into your ducts. Ayan yung mga ducts nyo or ductules. Ayan, ducts. So yan po yung nangyayari dito sa ating milk ejection. But please do not be confused as to the function of oxytocin and prolactin. Ayan prolactin and oxytocin. They are in concert with another, but then again, the function is different. Prolactin is for milk production. Oxytocin is for milk ejection. So, syempre, dapat kasabayan sila kasi pwede naman din na may milk production kids. But there are really times na maraming ganito yung problem sa mga mothers na although milk is really being produced in our mammary, in the breast, but if oxytocin is not present, wala pa rin pong lalabas. So kaya nga dapat kasabayan sila because prolactin is for the production, oxytocin is for the ejection para lalabas yung milk dun sa ating nipples, and then of course for our baby to be able to drink the milk. So again, please do not confuse the roles of prolactin and oxytocin. Prolactin is for milk production, oxytocin is ejection. So any excess or deficiency of oxytocin is rare and there are only limited case reports. Measurement is even extremely rare. Half-life of your oxytocin, grabe kababa kids, paspas kayo na siya mag-degrade, only around 3 to 5 minutes because of the presence of our enzyme oxytocinase. If mag-measure man ng oxytocin, usually mga immunoassays siya. Then again, yun na nga, wala po talaga tayong testing nito. I never heard also of someone na in need of oxytocin testing. And kindly take note, both sexes actually secrete oxytocin. Diba? Yung functions na nasabi natin kanina, it actually focuses on females. So what about its role in males? Kasi nga, uterine contraction, milk ejection, sa babae naman po yun. Di naman po nabubuntis si lalaki. So what is the role of oxytocin in males? One is during ejaculation. So para siyang pang sperm ejection, pang ganun. And then it involves in facilitating sperm transport due to its presence in your seminal fluid, and it may also have effects on some aspects of male sexual behavior. So oxytocin will have an effect to the production of your testosterone kasi that will also affect the production of your sperm. So some interesting facts about your oxytocin. Oxytocin promotes attachment, it actually solidifies relationship, it eases stress, it crystallizes emotional memories, it improves your social skills. So daghan day kaayo og effect sa oxytocin pa kids na dili lang yun kaayo po nato mapansin. It triggers protective instincts, it induces sleep, and it fosters generosity. So in short, keep calm and release oxytocin. So that's it for your oxytocin, and that's it for our discussion about your posterior pituitary gland. So if in case you have questions, kids, please do not hesitate to message me or bring it up during our classes. So thank you so much for listening, and I hope you understood the lesson well. Bye, kids!